Hello, I'm Mike Darcy. I'm the Chief of Interventional Radiology at Washington University here. And we'll be talking about uterine fibroid embolization, particularly the techniques and some of the results. First of all, what is uterine fibroid embolization? We typically refer to it as UFE, and this is a minimally invasive procedure. It's important to recognize that this is not surgery. This is a procedure done by interventional radiologists who are physicians like myself who have training in using imaging techniques to guide our procedures without actually making large incisions. UFE is typically done through a small skin nick down in the groin. It's not even big enough to put a stitch in and typically does not leave a visible scar. As I mentioned, this is an image-guided procedure, so we do use a small amount of fluoroscopy to monitor what we are doing, although the radiation associated with this is very minimal since we closely shield the patient during the procedure. Now, the rationale for UFE is shown here. First of all, embolization in general is just the process of injecting material into arteries to block the blood flow. In uterine fibroid embolization, what we're doing is injecting material into the arteries that specifically supply the uterus, and therefore we block the blood supply to the fibroids. The lack of blood supply to the fibroids then causes them to die, and as they die, they soften and shrink. Now, in what patients do we do UFE, or why do we do it? These are the most common symptoms. Excessive heavy menstrual bleeding is one of the most common. But then we also see a fair number of women who have what we call bulk symptoms, and these are listed here, and this includes pelvic pain or pressure, frequent urination, urinary urgency, constipation, pain during intercourse, or sometimes even back pain. And the image on the right is an MR scan showing how this could occur. The yellow arrow points to a very large fibroid in the uterus, whereas the red arrow points to the bladder, which is significantly compressed by the enlarged fibroid. Now, this is an image showing the physicians who do uterine fibroid embolization in our group. And when you come for a clinic visit to discuss this procedure and see if you're a candidate for it, you will meet one of these physicians during that clinic visit. Now, preparation for the procedure is listed here. The night before the procedure, you should not have anything to eat or drink after midnight, and this is primarily so that we can safely sedate you. Hospital policy indicates that we cannot give a person sedation if they've had any food within 6 hours, so you have to have a relatively empty stomach, and I say relatively because we do want to make sure that you take any medications that you normally take and just take them with a sip of water. What we don't want is the person showing up not having taken their high blood pressure medicines, for example, and have their blood pressure be through the roof. You will typically come into the hospital the morning of the UFE procedure. You will have an IV placed for which we use to give medications and hydration. The IV hydration is important because it helps limit some of the symptoms that you have afterwards. And then you'll also be given a number of medications, what we call pre-medications, to help fight nausea, inflammation, and also an antibiotic to prevent infection. When you're called down to the interventional radiology suite, one of our nurses will check you in, and she or he will look at your chart. They will also make sure that you have a functioning IV. At that point, one of our physicians will also have you sign the consent form and answer any further questions that you might have at that point. This being a large teaching institution, we sometimes have residents or fellows go up and see the patient on the floor before they come down to our area, so you may meet one of the trainees initially, but rest assured that the attending physician that you met in clinic will be actively involved in your case, scrubbed in your case. There is no such thing as ghost surgery here. Now, this is an example of what an Angio Suite looks like, and this is the type of room that you would be taken in for the actual procedure once you've finished your preparatory steps. At the left of the screen, you see the imaging equipment that we use to actually generate the x-rays that allow us to guide our catheters and monitor the procedure. You will be on a table that will swing into the imaging equipment, And you can see in this patient, or in this case, the patient already has a sterile sheet on, and there's a sign pointing to where the access site is in the groin. And then the imaging displays in the upper right-hand corner are what we use to watch where we're guiding our catheters throughout the procedure. Now, during the procedure itself, there will be a nurse stationed at the head of the table, and the sole job of that nurse will be to take care of you during the UFE. That nurse is not participating in the procedure itself. They're simply there to monitor you. They'll be watching your pulse, blood pressure, and oxygen levels. They'll also be administering the medications that we use both to sedate you and to control pain. And they'll be communicating with you, making sure you're fine during the procedure. The physician actually doing the procedure will be positioned down by the groin, and in many cases you actually will have a fairly limited view of that physician because the imaging equipment tends to block your view of the physician. We start off by getting access into the femoral artery, and the area where we go into the artery is on the diagram on the right, circled in yellow there. And we go into the femoral artery because this is the easiest and safest place to access your arteries. And this is very similar to what you might have heard people describe for heart caths. To get into this artery, we first numb up the skin over this area. So there is a tiny needle stick involved in numbing this. But once we have the tissue over the artery numbed, you typically will not feel much else in this area after that. We then introduce a catheter, which is a thin plastic tube, into the arteries. And we start off by actually directing the catheter over to the left side. You do have two uterine arteries, one on the left side, one on the right side, and we are able to treat both of those from a single femoral artery puncture. And we tend to start on the left side just because that's the easiest for the procedure. Once we get into the region of the uterine artery, we then use some injections of X-ray dye to specifically find the uterine artery itself, and the image on the left shows us getting into what's called the internal iliac artery, which is the parent artery for the uterine artery. And then the bottom two images show us getting close to the uterine artery itself. The bottom middle image with the red arrow points to the uterine artery, and then the yellow arteries, or yellow arrows rather, on the right image show the very hypervascular or fibroid that has a lot of blood vessels going into it, and that's a fairly large fibroid in this particular case. Once we've gotten close to the uterine artery, we then pass a microcatheter, which is a very small 1 millimeter catheter, into the uterine artery itself, and the image on the right shows the microcatheter going into the uterine artery where the red arrow is. Once we have our catheter safely in place, we then inject these Embosphere Microspheres. And these are tiny microscopic spheres that will float out into the branches of the uterine artery and block the artery. These Embospheres are made of a material that's very similar to contact lens material. And the reason why we use these Embospheres in particular is because this is the one device that is specifically approved by the FDA for use in UFE procedures. Once we've embolized the left uterine artery, we will then redirect our catheter over to the right side. And the first image on the left there is a diagram showing us doing that, and then the subsequent two images on this slide show the catheter, which is where the red arrow is, getting into the uterine artery, and then injecting some dye outlining the uterine artery itself. During the UFE, you receive light to moderate sedation. This is a combination of fentanyl, which is a narcotic pain med, and Versed, which is a sedative. And the idea is to keep you comfortable, almost in a twilight type state, but not fully, totally asleep. The reason for that is that, for one, we need your help during the procedure. Occasionally we're going to ask you to hold your breath while we take some pictures. And secondly, if we give you too much medication, in other words a general anesthetic, you'd have to be put on a ventilator, and it's really not necessary to do that. aside from the initial time where we put the needle into the skin to numb the skin, you won't really feel the rest of the manipulations. You do not feel the catheter as it moves through your arteries. Now, towards the end of the case, you may start to feel some crampy pelvic pain, and this is just the body's response to having these fibroids killed. It has nothing to do with the actual manipulation of the catheter. Now, after the UFE, what can you expect? Well, immediately after the procedure, you will probably still be a little sleepy from the sedation. And during this time where you're waking up from the sedation, we'll have a short observation period in our interventional radiology holding area. The nurses will continue to monitor you to make sure that you're breathing adequately and that it's safe to send you back to the floor. You will be hooked up to what we call a PCA pump, and that stands for patient-controlled analgesia, and this is basically a pain pump. It pumps pain medication in that you control. And the big advantage to this is that if you are in pain and you want some pain medication, you can pretty much control it. You don't have to wait for a nurse who might be busy with other patients in the middle of the night, for example. The PCAs are very safe. They do have lockouts, so you can't accidentally overdose yourself. Once our nurses have determined that you are breathing adequately and you're in a very stable condition, they will send you back to your hospital room. The nurses on the floor will continue to watch your vital signs and make sure you're doing well. And then the only real restriction that you'll have initially is that you have to keep your right leg straight for about 2 hours after the procedure. The reason for that is that we need to give that little puncture site in the artery some time to heal before you start moving around. Now, later that afternoon or evening, it is very common for women to have some abdominal pain and or nausea. And these are part of what we call a post-embolization syndrome, or in other words, a complex of symptoms. The abdominal pain and nausea are really just reactions to the fibroids dying. It does not mean anything went wrong or that you're having any unusual problems. Now, as I already mentioned, we will have the PCA pump hooked up, so we should be able to control your pain with that. There will also be IV medications available to help control any nausea that you might have. Now, I will say that women have extremely variable degrees of these symptoms. Some women have a fair amount of pain, others have very little. Some have very little nausea, others have a lot, and some have both, or little of each. And we will titrate or fine-tune the medications according to what your symptoms are. Now, if you are one of the lucky ones who doesn't have much nausea the first night, you are able to eat, and the nurses on the floor will just watch and see how you're doing and judge what you can tolerate. Now, putting this in perspective, these sound like bad symptoms, pain and nausea, but if you think about the alternative, which most commonly is hysterectomy, you certainly would not go through a major operation such as a hysterectomy without having pain and, I dare say, some nausea as well. Now, the next morning, typically the pain and nausea should be significantly less, so much so that generally we're able to stop the IV pain meds and convert you over to oral pain pills. And also, you should be able to start eating food by the next morning. In fact, this is sort of the requirement to determine whether or not you can be discharged. Before we will discharge you, we have to make sure that your pain is controlled on pain pills alone, and we also need to make sure that you're able to take in adequate oral fluids and food because we don't want you to go home and get dehydrated. So if you're tolerating food and liquids, you will be discharged the next day. And 95% of women do go home the day after the uterine fibroid embolization. I will say that there are about 5% of women who have enough persistent pain or nausea that we have to keep them in the hospital an extra day or two, but it's rarely more than 2 days. You will typically be sent home on the medications that are listed here. There will be an antibiotic to help prevent any infection, but we also will send you home with an anti-inflammatory medication, some anti-nausea medications, something for pain, and stool softeners. And the last one is actually very important because you have these very large fibroids that are very close to the rectum, and when we do the fibroid embolization, it's not uncommon for there to be some irritation of the rectum, and so constipation is a fairly frequent complaint by some women, and therefore it's going to be important to be on stool softeners as well. As far as recovery goes, usually the first week after the fibroid embolization, you'll have some continued cramping and pain. You may have some fatigue, and as I mentioned, some constipation. The only real restrictions that you have, though, is that you will not be allowed to do any heavy lifting for about 24 hours. But after that, you're pretty much able to do whatever you feel up to doing. So whenever you feel ready to go back to work, you can. Now, in most situations, that's usually about a week and rarely 2 weeks after the procedure. But whenever you're up to it, you can. Now, how does this compare to surgery? As I mentioned, hysterectomy is the main alternative that has been used for treating fibroids for many years. And this slide shows the data from 2 studies, one that was done by Jim Spies in Washington, D.C., who's one of the world's premier researchers on the UFE procedure, and then another study that was done in Scotland that was called the Rationale. And what we see here is that if you look at the number of days spent in the hospital, the women who had the UFE had far shorter stays in hospital than those who underwent surgery. And then if you look in the right column under days until return to work, we see that the time spent off of work was about a third of those women who underwent surgery. So significantly shorter recovery period with UFE versus surgery. Now, although it's not surgery, there are still potential complications that you need to be aware of. Every procedure has potential complications, and the ones with UFE are listed here. Groin punctures, puncture site problems, including bleeding, or what we call hematoma, is basically like a big bruise under the skin, and that can happen. That's not terribly common. Cervical impaction is where a piece of the fibroid may drop off into the uterine cavity and get stuck in the cervical canal instead of passing. Now, typically, a woman will have some spotting and maybe even pass a little bit of tissue after a UFE, but if a large enough piece tries to pass, it may get stuck. And if that happens, you may get some crampy pain and fever, and rarely it requires that we ask the gynecologist to do a D&C type procedure to scoop out that tissue that's stuck. An even rarer complication, but one that everybody dreads, is infection of the uterus. This can be bad enough to require an emergency hysterectomy, but as I mentioned, this is very rare. There have only been a few case reports of this in the world literature, even though this is a procedure that has been done in many, many thousands of women. And then it is possible to cause premature menopause with this procedure, just because some of the beads that we inject can get into the ovary and may affect ovarian function, but this is also a fairly uncommon procedure, or complication rather. As far as typical results, 40 to 60% reduction in size of the fibroids is what is seen in most studies. And so, for example, on the left, you see a MR scan that was done before the fibroid embolization, and you can see that compared to the image on the right, the fibroids are larger. The other thing that you notice is that the character of the fibroids has changed. On the left, they have a certain signal characteristic, whereas on the right side, the fibroid that we're pointing to with the red arrow has become very dark, and this indicates that this fibroid has become devascularized, which is a medical term meaning the blood supply has been cut off, and so it is now dead. If you look at what the yellow arrow is pointing at, the yellow arrow is pointing at the bladder, and you can see that before the UFE, the bladder was very compressed, and afterwards, even though the fibroids haven't totally gone away, the shrinkage and the reduction in size are enough that the bladder is now able to expand better. Now, in addition to the shrinkage, as I mentioned earlier, the other thing that happens is the fibroids get very soft. Before embolization, the fibroid is like a rock-hard mass in the uterus, and then afterwards it becomes very soft, pliable tissue. And so the combination of the shrinkage and the softening of the fibroid will generally lead to improvement in symptoms in about 85%. So, as I just mentioned, 85% of women have complete or significant relief of their presenting symptoms. There are 15% of women who still have enough symptoms that they were not satisfied with the procedure. The first menstrual cycle that occurs after the uterine fibroid embolization is typically lighter than usual, but then subsequent periods tend to be more normal in character. Now, in terms of how patients respond to UFE versus surgery, in terms of improvement of their symptoms, this slide shows some of the data, again, from that REST trial that I mentioned earlier. And you can see that if you look at quality of life scores, in other words, this is a scoring system for determining how well a woman is doing in various categories, including physical function, pain, and general health. You can see there were really no significant differences between the fibroid group, uterine fibroid embolization group, and the surgical group. Now, the one difference was that the UFE group did have a higher incidence of repeat interventions, and that's because, as I mentioned, not all the women have shrinkage in their fibroids that is sufficient to relieve their symptoms. So what if the symptoms are not controlled? Well, the first thing we would do is get a repeat MR scan to see if the fibroids are still alive, because there are other potential alternate blood supplies to the fibroid, and one of the most common is what we call an ovarian artery that normally would supply the ovaries, but can also supply the uterus. And in some instances, that can be enough to keep the fibroids alive. If we find that situation, we will sometimes have discussion with the woman about whether or not we should go in and embolize that ovarian artery. A lot will depend on the age of the woman and how close she is to menopause, because that does increase the risk of ovarian dysfunction. But we would have that kind of discussion with you if that arose. And then the important thing to recognize is that hysterectomy is still an option. So if you're trying to decide between fibroid embolization or hysterectomy, it's not definitely an either or. You can undergo the uterine fibroid embolization, which is less invasive, and if you happen to be one of those unfortunate 10 to 15% of women who still have persistent symptoms, you can still go on to have a hysterectomy. The UFE procedure does not burn any bridges, does not make the hysterectomy more difficult. And this slide I put up here because this is just a testament to how well accepted UFE has become. These are statements from the American College of Obstetric and Gynecology's clinical management guidelines. In other words, these are papers that they put out for their members, the gynecologists, and basically saying what they think is the state-of-the-art literature. And they said in this most recent guideline, which came out in 2008, that based on long and short-term outcomes, uterine artery embolization is a safe and effective option for appropriately selected women who wish to retain their uteri. Now, they do also go on to say that the effect of uterine artery embolization on pregnancy remains understudied, and I would certainly agree with this. There are many cases where women have had uterine artery embolization and then gone on to bear healthy, normal children, but there are some studies that suggest that after uterine artery embolization, there is a slightly higher risk of complications during pregnancy, such as ectopic pregnancies. And so we don't really have enough data yet to be able to safely recommend UFE in women who want to have further pregnancies. So in summary, uterine fibroid embolization is a minimally invasive procedure. It's not surgery. The recovery period is much shorter than what you would have if you had a hysterectomy. And 85% of women will get either complete or very significant relief of their symptoms from this procedure. Thank you.